You know why we're launching the ITH. The problems are clear. The difficulties facing Canadian healthcare are known to all, personally and from a policy perspective. You know what it means for patients not to find a family doctor. You know what it means to go to an emergency department and the lines are and the wait time is exceptional. These are not accidental features, have become the persistent regularities of the Canadian healthcare experience. The details may vary from province to province, but similar troubles grip the healthcare system across Canada. So our starting point is fairly straightforward. It's not just a resource problem. Of course, resources matter, more resources help improve things, but what ails the Canadian healthcare system is not simply the need to allocate more resources. Already enormous sums of money have been spent on improving healthcare in this province and every other province, and the results, the outcomes have not improved enough or have not improved in the proportion of the money, the additional money spent. Thus, the issues are also organizational and managerial, and it has to do with how the system is structured, how the system is coordinated and governed. The second premise is that our system is filled with highly skilled and deeply knowledgeable and committed professionals who save lives every day through ingenuity, through workarounds, through persistence, and creative navigation of regulations. In other words, they deliver health care and best care for their patient despite the organizational conditions under which they toil, not because of those conditions were well designed. Thus, if we want better performance from our healthcare system, we need to focus more seriously on management and organization. So we have already discussed that we're focusing on these three areas of access to primary care, delayed surgeries, and emergency department overcapacity and wait time. They're not the only problems, but we choose to focus on them because they're the clearest points where Canadians encounter the limits of the current system. There are also areas where we believe organizational analysis and intervention can make the most difference. So our approach is shaped by two commitments. One, we take a systems perspective. We believe these problems are interdependent. Pressure in one part of the system quickly shows up elsewhere. Thus, we understand that solving these problems require managing this large web of relationship constraints, trade-offs, and interdependencies that constitute the healthcare system. Second, we'll pay special attention to the role of technology. Not technology as hype, not technology as magical thinking, but more technology as part of the practical redesign of systems, workflows, and decision-making. Technology as a solution grounded in organizational realities. How do we get there? This is a question that everyone is asking. And we are going to build the ITH through around three core sets of activities. First, real-world knowledge generation. We must first establish the key drivers of the problems and the root causes of bottlenecks in the system. To do so, we aim to mobilize McGill, sending dozens, if not hundreds of students, researchers, and professors into the field to understand in vivo and in collaboration with our stakeholders in the system, the processes and lived realities. Second, we want to convene and community build. McGill can serve as a non-partisan attractor, as a serious and credible setting that brings together clinicians, managers, policymakers, patient representatives, and researchers who all have a partial view of the problem. And the role of the ITH is to create this neutral space where these perspectives can be brought into dialogue and solutions co-created. And thirdly, and not last, is this transmission of solutions. It's not enough to generate knowledge or to identify potential problems and solutions. It has to be possible solutions have to be transmitted back into the system. It has to be in usable form. Innovations must be translated into policy development, into solutions that stakeholders can support and are actionable for implementation. Otherwise, good ideas go nowhere. In sum, the ambition of the ITH is to bring the organizational and managerial dimensions of healthcare to the center of the conversation. Thank you for being here. Thank you for supporting this effort. With that, I'll take my seat in the panel and actually start the chat. So I'm starting with Professor Jennifer Welch. The Canadian healthcare challenges, such as primary care access, emergency departments, congestion, and surgery delays, are often framed as specific to Canada. From your point of view as a public policy leader, are our healthcare challenges unique to Canada, or can we look to other countries for potential solutions?
Thanks so much. It's a pleasure to be with you. And unlike what the leader of Des Hotels mentioned at the beginning about healthcare experts being on the panel, I am an apple among oranges in that I'm not a healthcare expert, but I do know something about public policy. I just want to start, though, by underscoring the excellence that does exist. My son on Friday had a spinal fusion operation at the Shriners Hospital, and I've spent the last 3 days amongst the excellence that our system can deliver, including the surgeon who is a McGill assistant professor. And so I'm struck by that coming into the conversation, but of course I know where the challenges are. And I want to come back to something that Paul Genet mentioned, in that democracies as a whole are struggling right now. And what's interesting about that struggle is that it is not a questioning mostly about democratic values. It is a questioning of what democracies are capable of delivering in the 21st century. And healthcare is among the top 2 or 3 things that people focus on when they focus on delivery. And so I want to start with what is common and then go to what I think might be unique. We know from studies that have been done by the OECD late last year that public spending on healthcare is set to grow on average by 1.5% of GDP by 2045. Think about that number when you listen at the same time to those OECD politicians and what they're talking about when they talk about an increase in defense spending to meet NATO targets. Also a percentage of GDP. So the resource squeeze is big. At the same time, as we see across these countries, demographic changes through aging, also public expectations in the 21st century are a challenge alongside what we know is an increasing prevalence of mis and disinformation about public services. Technological change, another common opportunity, but also challenge. And also, this is something we're really seeing at the school when we talk to policymakers, the generational shift in the workforce, not just in healthcare, but in public services generally, and the stresses that that places on managers, but also on those seeking to innovate. So what are some of the things that might be unique to the Canadian context? Well, our funding model is not necessarily the same as the public funding model of other universal healthcare services. So that's something that we need to look at. Our type and level of decentralization in this country is quite unique. I can say that we have international students at the Public Policy School, and one of the things they say to me after they've been with us for about 3 months is they say, wow, you've got this dynamic of federal-provincial relations in Canada. And I smile and I nod and I say, oh yeah. And then when they do their policy lab projects, which are often engaging with that, they really understand what that means. Also, I think what's different is how our professionals are trained in the healthcare system. So can we learn from other countries? I just want to start by making one distinction that I think might be helpful, perhaps, Samir, for the work that you do, and that is between policy communication or transfer, we call this in the geeky public policy literature, and policy collaboration. What we often do is we look to other jurisdictions and we try to transfer knowledge, right? We saw this in COVID. We looked to see how others were dealing with the pandemic and we tried to mimic it. But what we need increasingly across jurisdictions is not just policy communication or transfer, but actual collaboration on shared challenges. And I think that will be important. I do think that there are, particularly within the EU, some innovative models we can look at on prevention and primary care access, on workforce distribution and retention, and on multidisciplinary teams delivering health services. And of course, we know that the EU in other domains of public policy has been a leader in terms of digital technology and AI, and I think there is more to learn there. So that's to get us started, Samir.
Thank you. Thank you. You're not off the hook yet. You mentioned the word politics and policy. So we know that reforms often stall at the political level. How can an institute like this one, that is positioned as nonpartisan, as evidence-based, and working collaboratively within the healthcare system, how can it help shift the conversation from ideological debates to pragmatic system redesign?
So the short answer is a ton, a lot. But let me just unpack that a little bit. So I would say to everybody sitting here that we are in a moment in this country where the problems that we face are too big for government alone. Government can do a lot, but the policy capacity of our federal and provincial governments has really dwindled over the years. And I'm sorry if there are public servants in the audience, but it's a fact that we observe a lot at the public policy school. Policymakers are telling us that they don't have the policy innovation capacity, partly because of the pressures they face, the speed of democracy to respond. And so we need, because we don't have the same think tank culture that we have in other OECD countries, we need independent and evidence-driven guidance for policy innovation. But we also need something else, which I've really observed, which I think your initiative can do, a safe, independent convening space where we can bring together researchers and policymakers and people from the private sector together, often behind closed doors, and universities provide that space. I'm really seeing the power since I've taken over the directorship of McGill that we have to convene. But I also want to make one last comment, that we should be striving for policy-engaged research. I think too often what we have done in universities is we have done our research and then we've gone and disseminated it or tried to disseminate it. Now it's really about the co-development of research solutions, knowledge production that is joint. And what we can do that government civil servants can't do is we can see around the corners. We can not just answer the questions that they come to us with. Please help us solve this. Okay, we can do that. But our responsibility is to see around the corners and say, have you thought about this? Because this is what's coming next. This is the question you should be answering. And I think your initiative is really well placed to do that.
Thank you. Professor Amélie Quesnel-Vallée, Canadians are proud of the universal access principles enshrined in the Canadian Health Act. The Institute's works emphasizes improving coordination and effectiveness of healthcare provision. In your view, do you see these efforts as strengthening or undermining the principles of universal accessibility and coverage tied to medical necessity?
Well, Samir, you know, as an academic, I am professionally obligated to answer an either-or question with, well, it depends. No, but seriously, I think our healthcare debates have too often fallen short because of false dichotomies. You know, the public system is inefficient, the private system is efficient. And that leads us into debates where we talk past each other and we talk across purposes. So I think that the biggest threat that's facing the public system right now is not privatization or delisting of services, though we need to be mindful of that and take care of that. But it is really that a nominally universal system that doesn't deliver is going to be losing trust from the citizens. And it harks back to what Jennifer was talking about. Why are we questioning what democracies are capable of doing? It's because these systems maybe that were designed in the past century are now showing some signs of strain. And so I think that if anything, what the Institute is the ITH is proposing is a way towards actually delivering on the promise of the Canada Health Act, on the promise of that universal access. Because quand on est sur une liste d'attente pour un guichet de patient orphelin pendant plusieurs années, ce n'est pas un accès au système. We have to recognize that, right? And so it is failing people and oftentimes failing folks who are in more disadvantaged positions, more so than others. So what I'd like, and it's going to be I'm going to problematize the question a little bit more. And I promise this is the only jargon I'll use, but in health equity research, health equity scholars, we try to distinguish two types of equity, actually. There's the horizontal equity, where you have equal access for equal needs. And usually in Canada, we think of that as without need to pay. And that's what we think of usually when we talk about the Canada Health Act and what it promises, one of the pieces that it promises. But there's also vertical equity. And that's proportional access based on that would provide greater access, faster access for people who have greater, more urgent needs. And I think that's something that I know that's something we all can get behind. And so what I'd like to see is that the ITH will actually be held to both standards and be looking at its work through both of those types of equity.
You're mentioning the fact that wait times and access gaps affect the vulnerable population more than others. And as a result, many Canadians are wary of efficiency reforms. So how can the Institute work in a way that we improve performance and yet we're not perceived as aiming to cut services?
Right. So you're hinting at the fact that, efficiency reforms, I'm thinking structural reforms of the 1990s, they hint at cuts, especially cuts in the public system, which tend to serve more destitute or more marginalized populations. So I think that word has indeed been weaponized in a way to justify cuts that end up disproportionately disfavoring some of those groups. So the Institute will need to be really careful in how it frames and communicates its work. But I see that going forward in two ways. So the first one is that, as I mentioned, equity has to be a design criterion for much of what it tries to do. And that's a simple question. It's asking, is a program that we put in place, who is it favoring currently most? And who are the populations that it should favor? And is it creating a gap? Because sometimes when we look at just the average, we're going to see an effect, a positive effect. But because we are already preaching to the choir, as it were, and bringing in folks who are already liable or already more likely to want to take up those innovations. And that's also to remind us that public trust isn't just built through a great communications plan, though I am sure we will have that being in the School of Business and being at McGill and supported by UA as we are. But it's also built through genuine engagement. And that's something that you have built into the ITH's work. And just as I want to kind of share a little anecdote that for me was really resonated with that and it shows how much it's a shift for academics also to bring in folks from the community, from the ground, practitioners, in the design of those questions to start from, and how not doing that can lead us sideways. So with D2R, DNA to RNA, another large McGill initiative where we tried to bring more accessible RNA therapeutics to greater slats of the population. We started out by going to les Premières Nations du Québec et du Labrador, the health directors of the Premières Nations. And our goal was to communicate how we wanted therapies, RNA therapies, especially those for rare diseases, which affect those populations disproportionately, to be available to them first. And our intent, we were proud of that commitment and we wanted to share it. And one of the health directors stopped us in our tracks and said, "What you're presenting as a privilege sounds to us like you want us to be your guinea pigs." And this still, to this day, is something, we need to bring. To me, it was a moment I had to take a step back and have the humility to look at my assumptions. I view healthcare as and more technological healthcare as a privilege. And I think many in this room probably share that view. And so not having had that opportunity to listen and to stop and to think about how that needs to shape the next steps of our work and building that genuine engagement, show up, do the work. It takes time. It's long, and it needs us to challenge our views that what we see as privilege, they may see as risk. And there's a very legitimate history to that, is something that I think the Institute will allow, that will make genuine change.
Merci, Amélie. Professor Sylvain Baillet, we're living in a moment where AI and digital tools are presented as solutions to almost every healthcare problem. From your vantage point, now leading a major health research institute and looking beyond the hype, what is your assessment of the possibilities offered by new technologies to help us improve healthcare delivery?
Thank you, Sam, because I think there's been a first discovery by the ITH this morning is that Samir goes by Sam. So thank you. Thank you for having me. And merci tout le monde d'être là et bonne chance, bon vent à l'initiative ITH. So to your question, Samir, I think, whether we're willing or not, we're facing this revolution. Whether we like it or not, we're going to have to deal with it, not only in the healthcare system, but in every, even in our personal lives. And we see that every day for pretty much everything we do. So there is no question that we have at least to interrogate ourselves whether, these tools based on AI and many aspects of AI, and there are new ones every day, are basically tools and instruments that going to be, levers to advance essentially the quality of care. And through the quality of care, I mean not only the service to the patient. We mentioned access. We mentioned also, the well-being of the healthcare providers. And what's also very important is to consider of course, cost. How healthcare, the best healthcare can be provided at the best possible cost, so to speak, from every vantage point. There's also the notion that, and I'm discovering that in my new role, that hospitals are incredibly complex organizations, and I would even say complicated organizations, generating thousands of data points, sometimes that are conflicting, just like opinions. And I think AI, based on big data, training and its capacity to find patterns and in this complexity are definitely, instruments you want to interrogate and you want to test. So you have to do this in a very responsible and educated manner. And that's also where the complexity rises. And this is the moment we are living in, because we are looking at, fantastic opportunities. There's indeed a lot of hype, a lot of fad in terms of, the big announcement behind what AI can do for in every corner of science, every corner of our daily lives, every corner of what's happening in possibly the hospital floors. But so there is a responsibility for our healthcare systems in association with academic units, including universities and all the different faculties and expertise in academia, to look at the benefits, but also the risks of leveraging AI tools for patient care, basically, and healthcare delivery. So, but if I go back to the notion that hospitals are terribly complex organizations, I believe in the power of organizations. I believe in the power of people in organizations, as long as the organizations are well organized. And often, what we can see is that it's a succession or layers of little hamster wheels that are basically doing their best to make the wheel turn, and sometimes there are even floors or between the layers of these hamsters that build their own wheels. And so there is this notion that you want to be able to find connections between these different layers and make sure that everyone at least is running in their own wheel in the same direction at least, and possibly making a bigger wheel turn properly for everyone. And so there are limits to metaphors, but this is basically what we are looking at: how to leverage these new tools in the best possible ways, considering privacy issues, responsible use, the fact that at the end of the day somebody has to be responsible for whatever decision has been taken with the assistance or not of an AI agent. And so these are all very open questions, and I'm looking forward to ITH to bringing the multidisciplinary expertise to first of all ask the questions that matter, so that eventually we consider the tools, maybe including AI, certainly including AI, to address these issues. Because often in innovation, including in healthcare, we are very much solicited by companies, external partners, and that's a good thing, that knock on our door every day. We are looking at more than 2,000, contracts we sign every year at the CHUM, and even more, solicitations. But often we realize that, first of all, some of these, proposals are solutions to problems that may not exist or are not well posed. And also, we have to realize that we cannot address all the problems at once. We have to prioritize and make educated choices on possible solutions to real problems, including, AI tools and technology.
Well, je vais te pousser un tout petit peu. I need to push a little bit. So would you suggest that the ITH gets involved in the evaluation of promising technologies that have potential to redesign workflow and improve coordination? Should we work closely to institutions like the CHUM or the MUAC to actually see how these technological innovation can be transformed into workable solutions?
Je dois dire que selon mon point de vue, c'est un oui absolument. Ça ne ferait pas de sens, selon moi, de rester dans une bulle purement académique, et je sais que c'est pas l'objet de l'ITH. Au contraire, l'idée c'est de ramener ensemble des spécialistes, oui, de l'expertise académique de multiples disciplines, y compris des spécialistes des sciences de l'implantation, qui sont une des forces, je crois, de McGill et également de l'Université de Montréal et notamment au CHUM. On a des spécialistes qui sont impliqués dans le processus d'innovation. Je parlais des 2000 contrats qu'on signe tous les ans, en grande partie pour tester de nouvelles solutions sur nos planchers cliniques. On implique systématiquement des spécialistes des sciences de l'implantation pour justement évaluer de manière systématique et rigoureuse le fait que telle solution qui a un problème en effet pertinent apporte cette solution de manière avec un véritable gain, non seulement peut-être financier, mais également un gain, bien sûr, pour les patients qui fait du sens. Et pour ça, il faut s'équiper de ce savoir-faire et de ce savoir-agir. So it makes it further beyond just these considerations. it makes complete sense that there needs to be a continuum between the intellectual and managerial considerations that are discussed and elaborated at the ATH with a transmission directly to the clinical floors and the administration of hospital. I'm going back to this idea that they go hand in hand. So I'm very happy and proud to be part of this adventure. So thank you again for this invitation, Samir. And I'm just looking forward to helping you make it happen, because it has to happen. And it has to happen between not only the McGill network of healthcare and health sciences, but also University of Montreal and other academic partners in Quebec and hopefully in Canada. But at least in Quebec, we are small enough to be organizable and to work together more, not in silos. And there is this tradition, and we want to break those silos and build bridges, and also to show, to lead by example. And so I'm very much looking forward to that.
Merci, Sylvain. I would like to thank the panel for these great answers. Do we have time for a couple of questions from the floor, or we are out of time? Okay, so I'll be glad to take a couple questions from the floor, though shorter questions would be preferred. Academics, they like to present and explain in great detail, and guilty as pleased, as claimed, yeah. Please.
I always like to talk about the living lab. And, so as the work is going on, is there a way to actually start it in the real system, and test it out like in a living lab, right? So ideas are coming out, but let's go try it to see if they actually work and does it really make a difference, and learn from some of the problems that it generates at the same time.
I think it's a great concern, and the point of the institute is actually to work closely with the stakeholders in the system and the hospitals and the institutions that are actually delivering healthcare. This is not going to be, let us come up with some great ideas, with all due respect to my esteemed colleagues. It's and we throw it into the system. It's more going into the system and finding out why are all those wonderful ideas not moving the needle, so to speak, not changing things. And we believe it's a co-production, it's a co-creation together with people in the system. When I go talk to stakeholders in the system, and I ask, have you innovated before? And the answer is often once. And that's it, because they learned their lesson, they got their fingers slapped, and then so we need to create a way that innovation can be co-created together. So that's absolutely the concern, and thank you for raising it. Another question? Please. Alan?
I'm Pavlanis from the Department of Family Medicine. It's not so much a question as perhaps a plea, but I've really appreciated your presentations, and I think you have already taken some of this into consideration. But as somebody who's spent his career with one foot in the community and one foot in academia, I've lived the disconnect. And what I'd like to plea for is that whatever we do, that we don't get stuck in number crunching and systems, but that we remember the humanity of healthcare. The relationships, the personal relationships are really important. I'll just close by saying that the 4 principles of family medicine, as put out by Ian McQuinney, include being a competent physician, which is okay, but it's important, but in this context, the second principle is that the doctor-patient relationship is fundamental to the practice of family medicine. And so if we crunch numbers and we look at systems, but we lose that personal relationship between, it could be a family doctor, it could be a nurse practitioner, I think that's irrelevant. But the notion of keeping the personal relationship as a lens through which we look at everything that we do. And the third and fourth principles are about being connected to the community, and you've already addressed that. But doing work with the community, with community involvement and the community participating in decision making and planning, I think is hyper important to the success of any kind of solutions that we propose. I don't know if you want to comment. I realize I did the professorial thing, I talked, but anyway, there we are.
So this is a great point. Thank you so much for raising it. I will say only two things. My personal experience, for instance, at the SHUM is that patients are partners of the organization and the management of the hospital. There is this tradition that is actually living every day, including at our own, executive board of the research center, where we have two patient partners that are there and that they are full members. They have voting rights, etc., and they bring an amazing perspective on things we are trying to do. That's the same thing at the level of the hospital, even at the conseil d'administration. The other thing I wanted to do, maybe it's a bit naive, I wanted to say is a bit naive maybe, but I'm going to try, is that if you increase efficiency in the system, hopefully you're going to free more time and mental availability from the practitioners who deliver healthcare towards the patients, meaning that they will feel less under pressure to see more patients and anticipate the huge amount of paperwork they're going to have to do in terms of reporting, faxing stuff, etc. So there is that too. It's not only numbers. I cannot agree more. But the numbers, if they are well processed, may free up and liberate some more humanity in the system.
I would add to that. I think one of the what the ITH is offering is a bit of a reshaping of some classical ways of doing academic work. So, professors, we do the research, we publish the research, we hope people read it, and that's not knowledge translation. That's optimism at best, right? And this ITH, the premise is that there will be folks embedded in these environments, and just as Jennifer pointed out, these international students coming to study the Canadian system go, "Whoa, you're actually a federation," and other things too. That is that insight of being in. With the practitioners, with the community, is what this institute will spark. We have a couple of experiential learning programs across the university, but historically, the incentive structure in academia has been publish, and get grants and publish some more. And this is shifting. So there are movements afoot to recognize impact in different ways, in more varied ways. And McGill is a signatory to some of these initiatives. And so I think this is also another example of, I'd like to think when things feel broken and dark, like they do a little bit right now, I'd like to think of Leonard Cohen's anthem, some of these verses. There's a crack in everything, and that's where the light comes in. And I'm probably messing it up, but that's you get the idea. And I think this is the kind of initiative that gives us a little bit of that ray of light. It's too much to put all the weight on it to be the light, but we need the hope. We need encouragement for change and more. More engagement with that and less punishment for failing and trying and making things better. So I think this is hopefully what the Institute will, or the ITH will live up to.
Maybe just two observations, and I really appreciated your comment. I mean, what struck me looking at some of the really comparative data across the OECD is that, yes, access to primary care is a big issue, but the level of satisfaction with primary care when you have it is incredibly high, which shows just the nature of the personal interaction that you're talking about. But more broadly, I think we are also at a time when the efficiencies, the technological changes we want to bring in create, in some ways, less human time, but I think they make us all think about what is it we want to be doing when humans are actually together in the same room. What do we want those interactions to be? And we're really trying to do that with our students at the public policy school, who are, they have very bright eyes about AI, about technology, but to say, what is it that we want to do in our human interactions alongside the introduction of these technologies? So I think your point really speaks to that need for us to never forget the importance of that.
Thank you very much, everyone. Thank you, panel. Thank you all for being here.